Hello, this is my presentation on agoraphobia. Agoraphobia is part of the anxiety disorders. If a situation is avoided because of fear when a real danger does not exist, it is called a phobia. A phobia is an avoidant behavior which interferes with a person's daily functioning and causes distress. Estimates in the community are 10 to 11.3% for phobias, 4.7% for panic disorders, and 1.4% for agoraphobia. Agoraphobia is fear and avoidance of two or more of these situations where escape or rescue is difficult in public transportation, open spaces, enclosed spaces, crowds, or standing in line, or being outside the home alone. Severe fear or panic-like symptoms can be triggered when a person feels trapped, embarrassed, or helpless. In Greek, the word agora means a gathering place or market. This anxiety disorder disrupts a person's ability to follow everyday tasks and routine. The persistent fear is excessive and not in proportion to the situation. Agoraphobia is more complex than fear of open spaces and can include remote or far from home places like bridges or traveling. Though they are two different disorders, a panic attack or panic disorder can develop into agoraphobia. After a panic attack happens in public, a person can develop anxiety for further attacks, so they avoid similar situations. A person can experience fainting, increased heart rate, falling, hyperventilating, incontinence, or other embarrassing symptoms. Thus, avoidance can make them afraid of leaving home, and they may require a companion to go outside. The symptoms affect females more than males, and usually in people 25 to 35 years old. The DSM-5 classifies agoraphobia as an anxiety disorder. Often a person with agoraphobia also has symptoms of panic disorder. In DSM-4, agoraphobia was described as a secondary diagnosis in the presence or absence of panic disorder. In DSM-5, it is defined as an independent disorder. Agoraphobia is one of the least studied disorders, with lifetime prevalence estimates for diagnosis with DSM-4 at 1.4% and with DSM-5 at 1.5%. What are the treatment approaches? Agoraphobia often occurs with other symptoms of anxiety and depression. A combination of medication and cognitive behavior therapy, or CBT, is used to treat agoraphobia. Antidepressants or anti-anxiety medicines can be prescribed to patients. Newer SSRI medications have less side effects, and they affect the serotonin levels and other neurotransmitters. So they are used currently. Using CBT, the client's symptoms of the phobia and causes of the anxiety are addressed by the therapist to help them face their fears. Through CBT, a client learns new ways of facing the triggers, situations, symptoms, and how to manage their fears and stress. Relaxation techniques and breathing exercises are used to reduce anxiety. Since the client might be afraid to leave home, the initial therapy is often online or on the phone. The therapist or helper or a helper might take small steps together with the client to walk away from home gradually, and the distance is later increased gradually to build confidence. So taking more and more steps away from home gradually. Agoraphobic exposure exercises are planned and assigned as homework for clients to do between sessions. Psychodynamic therapy is frequently used for anxiety disorders to explore the origins, meanings, and functions of the presenting anxiety to understand a client's overall personality. Questionnaires used to measure agoraphobia and panic disorder include Body Sensations Questionnaire, Agoraphobic Cognitions Questionnaire, Mobility Inventory, Beck Anxiety Inventory, Quality of Life Inventory, Beck Depression Inventory, and the Montgomery-Åsberg Depression Rating Scale. Krask and Barlow also recommend using the Anxiety Disorders Interview Schedule and a medical evaluation, and to also involve family members in the treatment. Compared to men, agoraphobia is more severe for women, and women tend to not seek treatment until symptoms become severe. So early detection, diagnosis, and treatment could be vital in preventing the worsening of agoraphobia. A study also found that agoraphobia with panic disorder in females was 3 times higher than in males. What are the goals of treatment? Agoraphobia often develops after a panic attack in situations including crowds, stores, theaters, confined areas including elevators, escalators, and basements, and even open spaces away from home, like waiting in line, being alone outside, and traveling by car, subway, bus, or plane. Goals of treatment include to reduce the fear through psychoeducation, to help a client understand their phobia, and to identify unhelpful ways of coping, including avoidance, distraction, alcohol, and substance use. Another goal is to reduce the intensity and frequency of the related panic attacks. In CBT, the components used are psychoeducation for control, monitoring of triggers, and monitoring of bodily sensations and symptoms, cognitive restructuring to correct the client's misappraisal of sensations as threatening, breathing retraining to help clients by distracting from the symptoms, progressive muscle relaxation to reduce tension, arriving at coping solutions and step-by-step problem solving to face fears with gradual exposure via guided imagery, simulation, virtually, and in real-life situations. Treatment also aims to increase self-awareness and to reduce acute fear of fear, which is due to interoceptive conditioning, for example, associating an elevated heart rate with a panic attack, and misappraisal of bodily sensations, for example, misinterpreting sensations as signs of dying or losing control. Another goal is to diminish the triggers and eliminate avoidance of the situations. Krask and Barlow developed a 4-part panic control treatment called PCT for panic, anxiety, and agoraphobia. So in that 4-part treatment, number 1 is through psychoeducation, somatic sensations are correctly interpreted and self-recording enhances self-awareness. Number 2, breathing skills help to reduce anxiety, and cognitive restructuring is used to replace biased thoughts with realistic thinking. Number 3, gradual interoceptive and steady increase of the triggers using simulation and virtual to in vivo or live exposure so that tolerance of sensations is increased. Repeated exposure reduces the strength of the response, resulting in habituation. This also shows the client that the aversive consequences don't happen, which results in extinction or counter conditioning. Number 4, planning for the future, including weaning off of the medications and prevention of relapse. One of the desired outcomes is self-efficacy, which influences how a person copes in threatening circumstances. Fear declines as control and confidence increase, while urges, behaviors, and emotions about escaping are reduced. After gradual exposure to feared situations for increasing amounts of time, a client can start venturing out from home to public venues. They eventually learn to set personal goals, for example, driving 2 exits on the freeway or going to the parking lot of the mall to reduce the phobia. At the beginning, this could be done with a helper or family member, and later the client is able to handle it alone. Fear is decreased as interoceptive exposure is used to reenact physical experiences, which helps clients reduce distress and understand that these sensations are not harmful. Thus, a goal is to increase the security, comfort, and confidence in the client so they can freely leave home and return to public places for work, leisure, and other social activities. And there are some cross-cultural issues related to agoraphobia. In general, there is insufficient access to mental health for people from low socioeconomic status due to lack of medical insurance, stigma, and financial constraints, while more females than men seek mental health services. The symptoms affect females more often than males and usually in people who are aged 25 to 35 years old, though a person of any age can develop this phobia. The overall anxiety disorders are more common in those from sexual minority groups and lower socioeconomic backgrounds due to stressors like poverty and access to mental health. Virtual reality has been used as an effective treatment of agoraphobia, but the VR field lacks scenarios which resemble a client's socio-cultural context. Including culturally relevant elements increases the validity of learning because it reduces the gap between the virtual and real life context. So while doing simulation or using virtual reality, the virtual reality needs to match the socio-cultural context of the client. So some authors working on this suggested 4 common scenarios in virtual reality, including having a house, elevator, park, and public transportation where exposure to anxiety triggers, for example, numbers of people, can be controlled and gradually increased. So this is done in virtual reality. There are some environmental issues related to agoraphobia. There is comorbidity of depression, other phobias, anxiety disorders, substance use, and factors like biological, younger age of onset, and social influences like not having a partner, divorce, or childhood trauma. So these are various environmental factors. Panic disorder tends to run in the family, and biological inheritance of having an overly sensitive nervous system can lead to negative emotions like sadness, guilt, anger, shame, anxiety, and panic. Lack of social support from family members can have an adverse effect on the client's mental health. There is a negative association between perceived social support and symptoms severity, as well as marital adjustment indicated a negative association between quality of support from the spouse and the severity of symptoms. So the more support you have, the more likely you are to get better. While specific and social phobias usually have an age of onset in the early teens, agoraphobia typically has a later age of onset. The prevalence among agoraphobics is the increasing expectation of functioning independently as an adult or taking on the demands of parenthood, while events like the birth of a child, feeling vulnerable after the loss of a support system due to death of a caregiver, or separation from a helping person. And then there are increased pressures at work, and all of these may precipitate agoraphobic symptoms when disastrous consequences are feared. So as a person goes through these life situations, they might fear disastrous consequences, and that might develop into agoraphobia. Childhood stress plays an important role in adulthood agoraphobia and social phobia, especially neglect, threat of physical violence, and harsh physical punishment showed an association to both phobias. In conclusion, agoraphobia can isolate a person to their home as they fear panic attacks will be triggered by going outside alone, or being in crowds, or in a line, or in open spaces, bridges, traveling, public transportation, and situations from which it is difficult to escape or to be rescued. CBT and anti-anxiety and antidepressant medications are effective ways to treat the phobia. In therapy, exposure to the triggers are increased gradually, and having family support is very helpful. Goals of treatment include reducing the fear and panic while increasing the security, comfort, confidence, and self-efficacy in the client so they can freely leave home and return to public places for work and social activities. There is insufficient access to mental health for people from low socioeconomic status due to lack of medical insurance, stigma, and financial constraints, while more females than men seek mental health services. Agoraphobia often occurs in conjunction with panic disorder. Panic disorder tends to run in the family, and biological inheritance of having an overly sensitive nervous system can lead to negative emotions like sadness, guilt, anger, shame, anxiety, and panic. Stress in childhood plays an important role in agoraphobia in adults. And that is the end of my presentation on agoraphobia.